Hi everyone, I'm Jule. Welcome to the Dysphagia Matters podcast. Julia and I are back from our summer break.
Hi everyone, it's good to be back. We took a little time off, went camping in the Netherlands, and now we're ready to jump into some new episodes with you.
And we've got a great one today. We're joined by Professor Taher Omari from Flinders University in Adelaide, Australia. He leads the swallowing research group there, and he's here to chat with us about the new Leuven consensus. Basically, that's a big project that sets out recommendations on how to look at pharyngeal and upper esophageal sphincter disorders using high-resolution manometry with impedance.
Taher explains the principles of pharyngeal high-resolution manometry-impedance and the diagnostic procedure, how the consensus was developed, and what it means for advancing clinical practice and research in dysphagia.
Enjoy listening!
Hello and welcome, Taher, to our Dysphagia Matters podcast.
Thank you very much. Thank you for the invitation to be part of it.
You and your co-authors recently published a paper with the title Defining Pharyngeal and Upper Esophageal Sphincter Disorders on High-Resolution Manometry-Impedance, the Leuven consensus. So this paper provides a classification scheme for the diagnosis of pharyngeal and upper esophageal sphincter motor disorders. So let's start with the basics. What is high-resolution manometry and how does it differ from conventional manometry?
Okay, well, why don't we go really basic and just talk about manometry first. So essentially, manometry is using a catheter with pressure sensors along it to measure the forces that are generated during swallowing of fluids and food. So the pressures that we're measuring result from the contraction of the swallowing muscles. And there's two different types of pressure that we measure. The intrabolus pressure, which is the pressure within the bolus domain, and then the contact pressures, which are the pressures that are being generated by the pharyngeal squeeze. So if you can imagine you have a catheter in your throat and you swallow a bolus through, and then after that bolus passes, the pharynx contracts and it brings the walls of the pharynx in close to the catheter, and then those walls squeeze on the catheter. So that's the contact pressure that we're measuring. So we're measuring these two different types of pressures to assess swallowing physiology. Now, high-resolution manometry is actually using sophisticated catheters that have a large pressure sensor array. So they have up to 36 pressure sensors spaced at 1 centimeter intervals. And this closely spaced center array allows us to measure the pressure very precisely across a large area, and that allows us to plot the pressure in terms of what's called pressure topography. So we can actually visualize that pressure plot and visualize the swallowing response as, if you like, a heat map. So the high pressures are, say, red pressures, and the low pressures are blue pressures. And you can see this map of the pressures over space and time, and that allows us to identify different anatomical segments along that pharyngoesophageal region. Now, it's actually the modern technique, and not that many people understand it that well, but it has been around for about 20 years now.
Yeah, that's great. Thank you. And we also face the challenge to describe something so graphical in a podcast, but dear listeners, have a look into the paper, and then I think it gets more clear when you also see the heat map that you just described.
Yes, that's right. There's a lot of examples in the paper, and this technique supersedes what we call conventional manometry, which is essentially an umbrella term for everything that happened before high-resolution manometry came into place. And these early studies were limited in the sense that they had fewer sensors available, so they couldn't generate the same types of topography maps. But there are a lot of excellent conventional manometry studies in the literature, and these often required simultaneous radiology to position the catheters appropriately relative to the upper sphincter region. And just because they're done with conventional manometry doesn't devalue those studies. In fact, some of the most important papers in the literature have been done with old school conventional manometry techniques. So I imagine that those that are interested in manometry would also be interested to go back and read some of those foundational papers because they're very important to our understanding of how to use this technique.
And where does the impedance measurement come in? What is it? What is it used for? And how does it complement the high resolution manometry then in the assessment?
Yeah, so the impedance is really important. Impedance is, as a technique, has been around, I guess, in clinical gastroenterology, since the early to mid 90s, and was used to measure bolus flow and also reflux as a test for reflux disease. But the way it works is that the high resolution manometry catheters have electrodes along them. Now, the sensors, the pressure sensors, are at 1 centimeter spacing. The impedance electrodes are at 2 centimeter spacing. So they give us a segment of 2 centimeters along which there are 3 pressure sensors. And across each of those segments, the system is passing a very weak electrical current. And what that current can do, because it's a constant current, if you pass something across those electrodes that is conductive, then that will change the voltage that's being measured by the system. And so we get a waveform that tracks the flow of the bolus. And so we can actually visualize, in the same way that we visualize pressure, we can generate impedance maps that show us the bolus flow, and we can see that bolus flow and presence without any radiology.
And how do these two techniques combined then improve our understanding and diagnosis of pharyngeal dysphagia?
Yeah, well, they're extremely powerful when used together in an integrated fashion. So what they provide us is a very comprehensive way of objectively measuring pharyngeal swallowing from a physiological and biomechanical perspective. So if you imagine that the impedance detects bolus presence, I'm sure the speech pathologists in the audience and yourselves understand that when you look at radiology, you can see pre-swallow bolus presence as a marker perhaps of poor orolingual propulsion or control, and you also see post-swallow bolus presence as a marker of bolus residue or pharyngeal efficacy of bolus transport. So you can actually measure those features with impedance. But impedance is also a good measure of bolus distension, so the actual area of lumen that it expands to. And so what we found is that it's actually quite a good marker of the upper sphincter opening. So you can actually make an inference about the extent of opening of the lumen at the level of the pharyngoesophageal segment. Now, if you can integrate those pressure measurements together with the impedance, you get, for example, in the upper sphincter, you can not only see the opening of the sphincter, but also the pressure relaxation of the sphincter and how much residual pressure there is in the upper sphincter while it's open. And if we think about the hyperpharynx, we can see when the hyperpharynx is distended, and we can see when the bolus maximally distends the hyperpharynx and map to that point of distension the pressure that you're measuring as a fairly pure marker of intrabolus pressure, as a way of assessing how much resistance there is to flow across the upper sphincter. So there are a number of things that we get quite easily, and we can derive these metrics with algorithms from the plots. So it's actually quite simple to do, even though it sounds complicated.
And based on what you've just described, kind of the other way around, which signs and symptoms are then indicating for us to use pharyngeal high-resolution manometry impedance in clinical practice?
The main indications and contraindications for manometry is something that we did explore in the working group paper, and so it is explained in there. And essentially, the working group felt quite a strong recommendation that manometry could be used to confirm and quantify pharyngeal contractile dysfunctions and dysfunction of upper sphincter opening in patients where these abnormalities have been suspected, either because of the patient's history or based on other imaging tests. So we know that manometry can be quite a good test to detect and quantify failure of relaxation and opening of the pharyngoesophageal segment. We know that it can measure the propulsive forces generated by the pharyngeal muscles. So if this kind of information is helpful to guide therapy or provide a baseline against which the efficacy of a therapy can be assessed, then it's strongly indicated in those circumstances. There were also some other indications. Perhaps these are a bit more speculative. They need maybe to be teased out a bit more, but certainly if there's a situation where other instrumental assessments are difficult to conduct or can't be performed, for example, the patient can't be transported to a radiology suite, then manometry may have a role in that setting. And we've certainly, in the context of our research program, done several studies in the intensive care unit where manometry can actually be performed quite easily in patients. Manometry may also be helpful to rule out a dysfunction in the context of a possible functional dysphagia. And in the same vein, if the other instrumental assessments are deemed normal, then manometry may actually pick up some subtle changes in swallowing function that may underlie symptoms. And finally, manometry may have a role in objectively tracking changes of swallowing function over time. So, for example, to quantify the progression of a degenerative or neuromuscular disorder, for example.
So it's a little bit similar to fees, I guess. You can use it at bedside. It's a little bit more feasible maybe in some clinical situations. But I remember having it done on myself that it's not the most pleasant thing. I mean, it doesn't hurt, but there are more pleasant things I could imagine. So are they maybe just beside that some might feel like it's not tolerable? Are there any really contraindications to pharyngeal high-resolution manometry impedance?
Yeah, you're absolutely right that there are some parallels with fees in many ways. I've myself undergone many manometries over my years of research, and you are right that it is somewhat unpleasant, but we do find that patients can tolerate this procedure very well. You know, at the end of the day, we're looking to provide a more comprehensive assessment of their swallowing, and in that sense, patients are happy to undergo the procedure. There are some contraindications. I'm sure many of these overlap with contraindications for fees, but of course, if the catheter needs to go through the nose, pharynx, and into the upper esophagus. So if there's any reason to suspect that that passage would be obstructed or that it may cause perforation or bleeding, those sorts of things, they are clearly contraindications. It can be done as a standalone procedure or in conjunction with imaging assessments. So if, for example, a patient were to have a severe stricture or other restriction at the upper sphincter, then it would probably be contraindicated to do this as a standalone procedure, and that it would probably be better to do it in conjunction with radiological imaging, just to be safe. The other aspect of the test is that it requires that the patients swallow fluids. So clearly, if a patient is a high aspiration risk where the aspiration risk can't be mitigated by controlling bolus size or viscosity or using some sort of compensatory technique, then would probably be contraindicated as a standalone assessment. But again, if done simultaneously with radiology, it may be performed. And of course, patients need to understand why they're having the test. So they need to be willing to cooperate. And if they're unable to comprehend or follow the instructions, if they're agitated by what's being done, and even if the study starts, if they're unable to tolerate the manometry catheter due to discomfort or gagging, those sorts of things, then it may be necessary for the person performing the test to actually abort in those circumstances.
Is it also performed with children?
It can be done with children, but in terms of what we've proposed in this working group paper, we didn't actually address pediatric use as certainly something that needs to be done in the future. It is certainly possible to do pharyngeal manometry in children. You can buy systems with catheters that are small enough. But in terms of standardization of procedure and recommendations for clinical use, that's still something that isn't available yet, something that needs to be worked on.
And you've also described a diagnostic procedure in this consensus paper. Could you maybe walk us through what this looks like?
Sure. Look, it's a fairly simple procedure to do as a standalone test if that can be indicated in a patient. If you have to do it simultaneously with radiology, that adds a level of complexity to this, but I'll just sort of walk you through perhaps a standalone test as a way to do this procedure. So essentially, obviously, it's an intubation, so the patient needs to have arrived fasted. And we do ask patients to discontinue drugs that will affect their pharyngeal swallowing. So the test is done with the patient seated in a head neutral position, and we'll give a local anesthetic spray to help with comfort, just to reduce the sensation around the nose as the catheter is being passed. And we tend to try to use this local anesthetic judiciously, and there is a little bit of literature on this. The literature is fairly mixed in terms of whether any effects on swallowing are seen. So the general recommendation from the working group was to use local anesthetic because it will increase the chances of a successful test. So when we pass the catheter, obviously it goes through the nose, and when it reaches the pharynx, we ask the patient to do a chin tuck and just take a few small sips of water, and that helps get the catheter across the upper sphincter. And then once across the upper sphincter, we can position the catheter so that the most proximal sensor is above the velopharynx. And that means that the catheter will straddle the entire pharynx from velopharynx all the way through to the transition zone of the esophagus. So once it's in place, we just tape it to the nose, and then we allow at least 5 minutes for the patient to accommodate to the catheter. So usually what happens is it causes a level of sensation that leads to swallowing, and patients will swallow a lot, but then that usually settles down within 5 minutes. Once the patient is used to the catheter being in their nose and in their throat, then we can start to administer bolus challenges to them. And we try to capture any challenge we give in triplicate, so do it 3 times. We're aiming to get a single swallow for each challenge, but that's not always possible. And then once we've completed the protocol, then we'll remove the catheter. And in our center, the entire study from start to finish takes anything from 15 to 30 minutes, depending on how it all goes.
Yeah, great. And then you've completed the procedure, and what physiological parameters do you assess then? What do you measure?
Sure. So we have some strong recommendations around the metrics that we should measure, which we can derive using software that's available to people that are doing manometry. And there was a working group initiative that was completed about 5 years ago that involved this Delphi consensus process. And that came up with 8 metrics that we measure. And these metrics define the contractility of different pharyngeal segments, velo, meso, and hyperpharynx, as well as the relaxation and opening of the upper sphincter. So the residual pressure within the upper sphincter, as well as the duration of relaxation of the upper sphincter. Opening of the upper sphincter, as I mentioned, you can infer from impedance. And we also have a metric that defines the resistance to bolus flow, which is intrabolus pressure, which we can measure in the hyperpharynx. So they're the key metrics that we use. We can also measure a number of other things as well. And these metrics include the pressures within the upper sphincter before and after the swallow, the pressures within the the proximal esophagus, and also other impedance-derived metrics of bolus presence, flow, and clearance. But those additional metrics, there's no consensus around how they're used diagnostically. So those measures of contractility of the pharynx and upper sphincter are the ones that we focus on in terms of physiological parameters to measure for diagnosis.
Yeah, and what do you think do they tell us about swallowing mechanics then?
What they tell us is, if we think about the upper sphincter, the relaxation and opening of the upper sphincter and whether that region is functioning normally. And so if it's not functioning normally, then we see in these metrics changes such as high residual pressures in the upper sphincter, a short relaxation time of the upper sphincter. We may see diminished opening of the upper sphincter and elevated intrabolus pressures above the upper sphincter. And in terms of contractility, we can measure whether contractility is, in terms of the pressure generated, whether that pressure is high, normal, or weak. And so if those pressures are weak, for example, then that may mean that the pharynx is less able to propel a bolus or clear the residue of bolus after the swallow.
You mentioned that also through impedance, you can measure bolus clearance and residues. So, because I think this question would come up for many people, especially speech language therapists, is it also possible to measure aspiration or penetration?
Unfortunately, no. We can't measure aspiration and penetration directly, but what we can do, and this is something that we've explored in a number of papers over the last 13 or so years, and that is to recognize that aspiration or the causes of aspiration are multifactorial. And we are measuring a number of different features of swallowing. So if we marry together information about bolus presence, information about strength of contractility, information about resistance to flow, if we combine those features together, we can actually develop predictors of aspiration risk. So whilst we can't measure directly, we can actually make inferences about risk of aspiration. So we've done this in a few different ways. We do have a sort of an empirical score that we call the Swallow Risk Index, which we published a long time ago, which we still use today because it's quite a good metric that we can see differences in relation to interventions and changes of swallow bolus conditions and other things. We've also explored using artificial intelligence, so neural network models, to look at multiple variables that link to aspiration and bring them together to find optimal predictors of aspiration. So whilst we are developing these predictors, they're still very much a work in progress, but it's certainly the results that we've published are quite encouraging in that regard.
Yeah, sounds very interesting. The term bolus pressurization patterns was mentioned in your paper. What exactly are they and why are they clinically important?
When you're doing a manometry and you see an abnormally high pressure during bolus flow, then that is something that you can actually quite easily recognize on the plots. And the paper actually shows a number of different examples of these patterns. And the key aspect is that the pressures are going up when the bolus is flowing. So these are not pressures that are due to a contraction of the lumen, they're due to distension of the lumen. And they're actually a marker of an obstructed lumen. So if you can imagine a pipe that has an occlusion or a narrowed segment along it, and you're trying to force some fluid into that pipe, the pipe above the occlusion will have a high pressure, and the pipe below the occlusion will have a low pressure. And the point where the pressure drops from high to low will actually be the point where that occlusion or narrowing is located. And essentially the same thing happens in the pharynx and the esophagus. So when we see this pressurization pattern, we recognize it as an important biomechanical marker of obstruction. And we know from esophageal physiology that patients with an LES dysfunction, such as achalasia, that some of those patients will demonstrate bolus pressurization patterns that can respond well to esophagogastric junction dilation or a myotomy of the lower esophageal sphincter. And so we believe that the same applies to patients with upper sphincter dysfunction, whereby the existence and potentially the type of pressurization may guide treatment. Of course, this is something that will require confirmation moving forward. So, but we're nevertheless recommending that these patterns are recognized because we believe that they will have a role in the future.
Sounds promising. You also introduced the Swallow Challenge Protocol in the consensus paper. What does it involve?
Sure. So the recommended protocol is essentially a way to do the study in terms of the challenges that we give. And this protocol is very much directed towards diagnosing upper sphincter dysfunction, because we know that if you're doing manometry, you can completely miss an upper sphincter dysfunction if you don't challenge the swallowing system sufficiently. So essentially, what the protocol recommends is that clinicians administer triplicate challenge of 5 ml, 10 ml, and 20 ml fluids, and then they also give a 10 ml viscous fluid. It sounds like a lot. It's not tolerable for every patient, but it can be tolerated by many patients in our experience. And so once you've done this test, if you're able to follow the protocol, then a diagnosis of upper sphincter dysfunction on manometry criteria alone is possible. And in order to do that diagnosis, you need to firstly demonstrate abnormal features that point to an upper sphincter dysfunction with at least 10 ml volume. But in addition to that, you need to demonstrate that these abnormal features get worse when you increase the volume or the viscosity. So, for example, a patient with an upper sphincter dysfunction that has a high residual pressure, it's important to detect that high residual pressure and not only detect it with a 10 ml volume, but demonstrate that that pressure will increase when you change volume or viscosity. If you can't demonstrate that, then you'll need to rely on other aspects that may confirm or support a diagnosis, but that may require recognizing pressurization patterns or relying on imaging assessments and so forth. So it won't be a reliable diagnosis in the opinion of the working group.
Yeah, okay. And what are some last key recommendations for the diagnosis of pharyngeal contractile dysfunction that you agreed on in the consensus paper?
Sure. Well, the first thing to say about observing abnormalities of pharyngeal contractile dysfunction is that just about any protocol will be able to detect that. And so whilst we have quite an elaborate protocol, that's the reason that it's so extensive, is to really understand what's happening at the upper sphincter level. In terms of what's happening in regard to pharyngeal contractility, we can assess by looking at the measurements we make whether contractility is abnormally weak, so it's hypocontractile. So, for example, that may tell you something about velopharyngeal insufficiency if it's weak in the velopharynx. It may also be an indirect marker of poor swallowing efficacy if it's in the meso or hyperpharynx. And so assessing whether the contractions are weak is potentially quite important from the point of view of a clinical assessment, and that may potentially guide a swallowing intervention in a particular patient moving forward. You can also see that pharyngeal contractility can be abnormally strong, so it's hypercontractile. And this may be secondary to upper sphincter dysfunction. So if you can imagine, if you have restricted flow at the upper sphincter A compensatory response to that may be to generate higher contractile pressures upstream to help drive the swallowed material through a restricted upper sphincter. The way we characterize these different patterns is to focus on, firstly, on evidence as to whether contractility is weak, and to define that contractility in terms of the extent of weakness. So is this a global weakness of the whole pharynx? So all segments of the pharynx demonstrate weakness? Or is it something, a weakness that's only demonstrated by one or two segments, not all segments, and therefore it's what we call fragmented? We think that this distinction is important to define whether someone has a global weakness versus a fragmented level of weakness within the pharynx, although, again, this is something that needs to be explored in the future. If the contractility is not weak, then we look to see whether the contractility is strong. We don't, at this stage, distinguish between whether hypercontractility is global or fragmented, because there was insufficient agreement amongst the group as to whether that was an important distinction to make at this time, where we're still exploring the clinical relevance of the measurement of high pressures within the pharynx of patients with dysphagia. If the contraction is neither weak nor strong, then there's no evidence of pharyngeal contractile dysfunction, although it's important to recognize there may be other evidence of other dysfunctions, such as abnormal aspects of bolus transport that may be missed with the current metrics and criteria as laid out. So we need to just caution people that just because the contractility appears normal doesn't mean that the patient's swallowing function is necessarily normal also.
I wonder, are there specific disease groups or populations where there's more like a global pharyngeal weakness, or rather a fragmented pharyngeal weakness, or general the pharyngeal weakness?
Global weakness we certainly see in patients that have myogenic disease, such as patients with inclusion body myositis would typically show global weakness, which extends not just to the pharynx, but to the upper sphincter and proximal esophagus. Patients that are post-head and neck cancer, chemoradiotherapy and surgery often present with global pharyngeal weakness, but in many of those patients, you may see intact upper sphincter pressures. So it's purely the pressures above the upper sphincter that will be weak or absent. But in patients with other range of different presentations typical for a dysphagia cohort, then you may see that the pressures may be weak, but they may be isolated to one region. So, for example, in the hypopharynx and mesopharynx, where a patient has significant post-swallow residue because of that weakness, that's not uncommon to see in many patients that present with dysphagia symptoms.
Okay, to wrap up the episode, let's have a look into the future. You already talked about some topics that might need or that will need expanded investigation. What are some areas of future research or also clinical application that you are especially excited about?
Well, the most exciting thing, I think, is if we just stay in the moment where we actually have a consensus. This is something that's been talked about for quite a few years now. So it's actually very exciting that we've actually come to the point where we have a clear recommendation that clinicians can follow, and we're hoping that this will guide future clinical trials in terms of diagnosis of dysfunctions that may be targeted with particular treatments based on specific enrollment criteria. And we're hoping that the results of such trials may feed back to potentially improve the recommendations that we've included in this consensus paper moving forward. So this is a first iteration of something that we hope will be revised in the future as time goes by, as evidence emerging from this guidance starts to appear in the literature and then can be used improve the guidance as we go forward. In terms of the deliberations we had, of course, we talked about a lot of different aspects when actually working on the consensus recommendations, and there are many other aspects that should be considered as for future directions. And we're hoping that, again, this is the need for this information will drive further research and will provide topics for many PhD and other students to investigate as part of their research. One of the things that is clear is that the metrics we've included in this, the diagnostic algorithms and in the guidance, are limited to a relatively modest number of metrics that a group of experts could agree on. But there are many other things that we can measure with this technique, that we do measure, that we report in our papers. And as someone who's been using impedance and reporting data on impedance for many years now, I certainly see a much greater role for impedance in the future in these recommendations, and we'll wait to see as more data emerges what happens with that. And there are a number of aspects with respect to protocol that can really be teased out. So what's the role of testing with real food? Should we be giving patients puree and solids? Now, that's a very legitimate question. I think it presents some challenges in terms of trying to produce a recommendation that's standardized, because those sorts of challenges are difficult to standardize, but nevertheless, I think it's quite legitimate that we should be exploring the role of those types of challenges and whether they have a diagnostic role. And also things that need to be explored are sensory stimulation, sour, cold, carbonated fluids. How do they change manometry? Do they have a role? Rapid drinking challenges is something that has emerged in the esophageal physiological testing. Does it potentially have a role, for example, in pharyngeal swallowing testing? The role of including swallowing maneuvers in terms of the manometric assessment. Should we be getting patients to do swallowing maneuvers? Should we be doing biofeedback? In other words, getting the patients to look at the manometry tracing and to practice maneuvers while watching the manometry tracing. These are things that are being done and being explored right now, but there's not enough data on these things for them to be included in a consensus recommendation such as this. Of course, there's other things that are unrelated to swallowing that manometry may have a role in. For example, patients with inability to belch, which is a clinical condition which has very much emerged in the literature in the last decade or more, and something that you can explore and diagnose quite effectively with manometry. And I'd probably finish by just saying that the pediatric world is still waiting for guidance. And unfortunately for them, this is an adult consensus guideline, and the protocols are not necessarily possible to achieve in children, but this is something that hopefully will be addressed in the coming years.
Yeah, thank you so much, and congratulations on agreeing on this consensus. I think it's a very important first step. And like you said, there's lots more to do research on. So if anyone is looking for ideas, here's the place. Thank you so much, Taher, for taking the time and for sharing your expertise with us and our listeners today. Thank you.
You're welcome. It was a pleasure. Thank you very much. I'd certainly recommend that anyone who has any interest in manometry, this would be your starting point, your entry point for this technique. And then once you've read the consensus paper, start to work your way back through the mountain of literature on this test. And hopefully, as time goes by, it will emerge as a important diagnostic for assessing swallowing in patients with dysphagia.
Yeah, excellent. Thank you.
Thanks so much for listening. If you enjoyed this episode, leave a review wherever you listen to podcasts. You can connect with us on Instagram, LinkedIn, and Blue Sky, or visit our website, dysphagiamatters.org. We'd love to hear from you. Until next time, take care.